de Prata, from Argentina to Uruguay. Ricardo.
Okay.
He's from Buenos Aires. Ricardo is from Montevideo. Please, Ricardo.
In my hospital, I had to fight with the surgeon for this patient.
Surgery.
Because it's a diabetic patient, has a long lesion in the LED, and he has two severe lesions in Chicago. So,
surgery or PCI? You refer to Washington.
Yeah, obviously, I'm interventionist, but I mean, look at this. I think by eyeballing, the LED is the severest lesion in this case. In my opinion, I would go initially for LED and then reassess the situation, but interventional therapy.
Okay, Alex.
Yeah, I think, Alex, we've given you all the options here, and I think there are different ways to look at that. Okay, I think the next question that we should discuss in this case is the bifurcation. How do you approach this bifurcation? I saw that you wire both of them, but then you have all those options, provisional, different techniques of bifurcation. What did you select, Alex, and why?
Yeah.
In the right.
So, okay, so let's go step by step. I thought that you guys would help me a little bit more. Yeah, I thought that you would be helping more, but I thought that there is no really consensus there. But let me share with you what we did. First, we decided to investigate the right. And what we did, we put an IVUS catheter, so we collect some images that Ricardo is going to show you. And then we also did FFR, just to really illustrate and to see if there is an agreement between the two methods. So this is the IVUS image of the RCA.
Yes. So basic, as you can see,
we are so curious to see both.
Yeah, the minimal
cross-sectional area on this IVUS was, the minimal CSA was how much?
3.5 millimeters square.
So I can tell you, without seeing the FFR, based on our study to try to correlate between FFR and IVUS, if you have a 3.5, the FFR would be normal.
Yeah.
That's in our, it used to be 4 millimeter, but in our data right now, over 200 patients, we try to correlate. The threshold is around 3.1, 3.2. 3.5 should be fine.
Even when you have a long lesion like this?
Even if a long lesion. In a vessel which is at 3.0, 3.5.
Okay.
If it's a vessel 2.5 and less, there is not good correlation.
So I guess your study it was right, Ron, because that's exactly what we found here. So the vessel, again, the minimum lumen area was 3.5. And if somebody can help us with the FFR, you see the images. For FFR, we got the number which will be shown in the screen. 0.84. 0.84.
And if I can make a comment.
The question now is, I don't know if the audience is brave to tell us what would he have done without FFR and IVUS. How many of you would have stented this if you didn't do FFR and IVUS before? You want to ask this in Portuguese?
I think it's quite obvious that we were over-treating this kind of lesions. This patient by no means needs treatment in that right coronary artery at this moment. And again, as I mentioned, and you ratify with your study, we have to move the area down of the IVUS in order to make it significant, and it's probably in the neighborhood of 2.8 or whatever. So I don't see by angiography that lesion needs to be treated. Obviously, the more FFR we do, the less stenting we do.
Yeah, but I think that can apply to IVUS as well. So what we're trying to prove that if you do IVUS and you have those measurements, it correlates very nicely with FFR, and then we don't have to pull two methodologies. If you do IVUS and you use the IVUS also for post-stenting, you can skip the FFR.
What would be the cutoff in your now?
So in our study right now, it's about 3.1. But again, we're doing a 300-patient study to corroborate this data. Park actually reported even smaller numbers. He reported 2.5, 2.8, but you have to be careful. In his analysis, he included 1.5 vessels and 2.0 vessels, and I don't think there is a good correlation once you go to such a small vessels. Maybe you don't have to do anything to such a vessel, but for when you're dealing the 3.0 and 3.5, the correlation works very well.
So, Alex, what do you have to decide for?
Yeah, we don't have much time left because we're going to show two interesting cases in the other labs. What we did here, I think we trusted FFR. There was an interesting debate at SCC, and even Gary Meets, who was a really strong IVUS guy, he convinced me that probably for intermediate lesions, FFR should be the way to go. So we trusted, although it's still in a little bit of a gray zone, somebody would say greater than 0.85 or 80 or 90 would give us a little bit more guarantee that the patient would not come back for that particular lesion. But we left it alone, and then we move ahead for the treatment of the left circ, which Ricardo and Rodolfo are going to show you. So those are the two lesions that you saw before, and now that's the treatment. We started with one Bioflex stent, 3.0 by 28, as you can see. It didn't cover the entire lesion.
With the PLA too?
Yes, it's Biolamus with bioabsorbable polymer. That's the most recent version that they were able to change a link between the cells and make the stent more flexible. And this is an additional.
Is that now cobalt chromium, or it's still?
It's still stainless steel. Still a stainless steel. So this is the second stent that we deployed with.
So looks great. The circ.
Yeah. 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 I'm pretty much convinced that with Medina 010, I think that I'm gonna try provisional. It's a favor angulation if I need to do T-stent afterward. So I will start. I would like to see your comments regarding the lesion preparation.
Do you think we should predilate or can go for direct stent in a case like this?
No. So, Chaim Lotan, what you shook your head no.
No, I wouldn't predilate. I wouldn't go without predilation. I would do the same. It seems
you would predilate,
calcified, and I'll definitely predilate, especially when you have two wires and you can get entangling of the.
But you're going to predilate both lesions or just the LAD?
In this case, I'll dilate only the LAD because we have cases in which you predilate and you cause a
dissection. Yeah.
Dissection, and then you have to go. So.
Is there anyone in the panel that would go directly?
One point. I think LAD is calcified artery, too calcified artery. I think IVUS is mandatory in this intervention previous to deploy stent.
I would say highly recommended. Mandatory.
There is stent is not an indication.
If you ask Fausto, he would say that he can do it without.
No, I can do with Angel. I have the case in from China to show you.
We had a long discussion in China a few weeks ago on that. But I think IVUS is helpful, but it's not mandatory. I mean, it's a recommended thing to do.
Yeah.
So you did pre-dilatation with a 2.5 balloon?
With a 2.5 balloon, and I'm also...
So the 2.5 or 2.0, Alex?
2.5. I thought that there was a lot of fibrosis irregular, a little bit of calcium, so I decided to go a little bit more aggressive, perhaps. But I think the IVUS discussion is an interesting one. I'm more prone to IVUS, as everybody knows, but I particularly for this case, I'm more interested about the IVUS post-intervention. I want to see perhaps the osteo of the side branch, if it's patent, if they have a good expansion. Sometimes IVUS changes my procedure or my strategy beforehand for the sake of time, and I don't think that it's going to add dramatically to this case. I don't know what you think.
So let me just do a very exercise with the panelists. What do you think should be the length of the lesion based on angio? If everyone can give you pick up the stent 3.0, what is going to be? 12, 15, 20, 28, 32? Give me just the number. I just want to see if there is consensus.
30.
30. Okay.
32.
32. Okay.
28, 30.
I think it's quite what balloon size you use as far as length. The balloon was 20 or what?
20.
15? The balloon was
20.
24 or so, something like that.
Okay, so we have a range from 24 to 32.
What was the balloon length, Alex?
I would cover
20.
Very much from above the diagonal to
20. It was a 20.
So I think it would be interesting if you would have done IVUS now and you change your mind, because you may take a longer stand because you'll appreciate more lesion, and the question also is how much you need to cover. We used to say we cover from normal to normal. You probably won't be able to do it, but I think it does help a lot in terms of...
What is the size of the stent length?
This is a 3.0 by 28. I would pick perhaps a longer one. We just are limited in terms of length here. This is actually a biomatrix, not a bioflex, just due to the limitation that we have in terms of length. But I think that 28, well, we'll decide together.